Today I'm going to be talking about IMT or Integrated Modalities Therapy for eating disorders. And for those of you who don't know me, I'm an assistant professor at Weill Cornell Medicine, which is the Medical College of Cornell University. I opened and directed the Eating Disorders PhD at New York Presbyterian Hospital for a period of time. And now I'm still there in a supervisory role, but I kind of stepped down from the director position in order to focus on IMT and publish these books. And the books in particular would be Treating Eating Disorders in Adolescents, and then also the client resource book that comes with this that is now available for free online at New Harbinger's website. So today we're going to talk about what IMT is, how it came to be, why an evidence-based practice model is used, and the basic components of IMT, as well as kind of give you a general feel of what the handouts are like. There are many, many, many handouts. I think there's something over like 250 handouts or something. So obviously we can't get into all of them, but I'll show you some pictures of them and give you a feel of what they're like and what the important treatment concepts are that are related to the specific selection of handouts. But next time we'll talk more about what the core IMT concepts are and about a selection of handouts in depth. So what is IMT? So it's a treatment for all eating disorders in adolescents. So it's transdiagnostic. It's an evidence-based practice model, which we'll talk more about what it is and exactly what that means. It includes a comprehensive collection of evidence-based interventions, and there's a group, family, and individual component components that comprise comprehensive IMT as a whole. And the IMT interventions are delivered depending upon pathology and level of care. And it's designed to be scalable and flexible. So an evidence-based treatment is a treatment that has a very specific protocol that has been researched and randomized controlled trials have been conducted on it. So examples include CBT-E, for adults, FBT for adolescents with anorexia and bulimia nervosa, most often more severe bulimia nervosa, and what we call the third wave treatments, ACT, dialectical behavioral therapy, compassion focused therapy. So that's what evidence-based treatments are. You're probably familiar with that, but what evidence-based practice is what happens when us clinicians in the trenches actually have to use these treatments, and maybe the treatments don't specifically address every need that the patient has, or we have to kind of retrofit it for a different level of care. So pretty much all of these protocols are outpatient protocols, but what do you do if you work on an inpatient unit and you have a patient that doesn't quite fit all the criteria that an evidence-based treatment would kind of require. And so you have to do your best as a clinician to figure out, based on what the treatment, the current evidence-based treatments are, what your patient needs, the setting that you're in, and your clinical expertise, what to do. So that's evidence-based practice. Now, what's an evidence-based practice model? It's it's not something that I've actually heard of before. It's more of something that I think Dina Hirsch and I, who Dina co-created IMT with me, we kind of dreamed up. So what we did is we essentially documented what we were doing in practice. So given the resources, given the patient's needs, given our clinical expertise, what we did essentially, or what we do with our patients is IMT. So we documented that. So rather than IMT at the current time being an evidence-based treatment, it's really a reflection of what we do, if that makes sense. So I'm realizing also that in this screen, I don't have access to the chat box. So I'm going to see if I can pull that up. Nope. Okay. So I think I'll kind of just break at some point and then look in the chat box, and then we can get to questions. Okay. So currently, the only evidence-based treatment for adolescents is really adolescents with eating disorders is really FBT. So FBT again is really for anorexia nervosa or AN, and kind of severe BN specifically. So it requires active participation of the family. Carers make, prepare, serve, and monitor the child's food intake. With people who are underweight, with adolescents who are underweight, this is done until weight restoration and or purging stops, and control is slowly given back to the adolescent over time. So many of you are likely familiar with FBT. I won't get too into it, but that's kind of the overall gist. So it might sound, for those of you who are not familiar with FBT, it might sound pretty coercive that carers or parents are taking control of food in this way, but really eating disorders can be so medically compromising that this kind of forceful approach is really needed. So we can have patients with abnormally low or slow heart rates, osteoporosis or osteopenia, severe dehydration, all of these medical issues, plus the adolescent might not be particularly motivated or might not present as particularly motivated to recover from the eating disorder. So lack of motivation kind of combined with these really potentially acute medical conditions really require a lot of parental involvement. Patients also could develop what's called refeeding syndrome when they have been dehydrated or malnourished for a long period of time, particularly over 20 days, and food is reintroduced into the system. Lots of medical complications could result: confusion, coma, convulsions, cardiac failure, and the like. So again, there's really a justification for such active carer involvement. There's also cerebral atrophy. So this slide shows kind of what your brain not on an eating disorder looks like on the left, and on the right, what can happen when a person is malnourished. And this is the cross section of a brain of a 14-year-old who has had anorexia or has active anorexia nervosa. You can really see the cerebral atrophy there and the enlargement of the ventricles to kind of fill the space. And so for the record, upon weight oh, there's the chat. Okay, let's see. So upon weight restoration, okay, sorry. Upon weight restoration, the cerebral tissue does actually regenerate, which is great. But there can be, we don't know all of the functional impairments. So a question came through from Becky: isn't CBT also evidence-based practice for BN in adolescents? Okay. So this is my understanding. So CBTE was really created for adults, and then there is, you can kind of use it for adolescents with BN, and it's also transdiagnostic. So you can kind of retrofit it for adolescents, but really it was created as an adult treatment, an evidence-based treatment. So regarding your question about evidence-based practice, yes, it's within the scope of your practice to retrofit CBTE for adolescents, but it wasn't really created for that population specifically, if that makes sense. Okay. So in terms of recovery rates with FBT, this study looked at adolescent-focused individual therapy versus FBT and found at 12-month follow-up that there is a pretty significant difference in terms of recovery rates. So the adolescent-focused individual therapy had a 23.2% recovery rate, and FBT had 49.3%, and that was significant. That said, and this is a slide looking at recovery rates, full, partial, and no remission for both adolescent-focused therapy and FBT. That's not really that high of a rate. It's the best we have, 49.3%. But compared to other disorders, this is actually pretty low. So we think of this whole area here that we marked off in red as the area for improvement, things that we can do. Plus, there's even more opportunity for improvement, because FBT is really a treatment that that really is for patients who have carers that are willing and able to participate in treatment. And unfortunately, for every adolescent, that's not always the case. Some carers aren't willing, and some carers are not able. So we really have kind of an even larger opportunity for improvement here. So we love FBT. We're big fans. And in fact, we kind of think of IMT as fan nonfiction, meaning we love the treatment so much that we decided to kind of expand upon it and use our own kind of creativity and ingenuity to figure out what kinds of interventions might be helpful in addition to it or alongside of it. So, so yes, there are certainly limitations with FBT, and completely for the record, we are big fans of FBT and very much, very much appreciate this approach. That said, there are pretty low recovery rates, not in comparison to other treatments for eating disorders, just in comparison to other diagnoses and treatments for other diagnoses. There are lower recovery rates. And again, there are very specific requirements for FBT, and there are a lot of difficulties that carers have when implementing FBT. So some of the kind of areas that we see with FBT that clinically are a little bit tricky is that no explicit direction is given. Parents are told to kind of rely on their instincts, and you kind of hear halfway through treatment sometimes, wait, my child can't help me prepare meals. And there seems to be some kind of confusion because it's not so explicit as a treatment. And parents are kind of encouraged to use past success at feeding their children when they were younger as a guide to the refeeding process. But a lot of times parents really just don't know what to do in the context of an eating disorder being present, and the eating disorder presenting as oppositional and defiant and all of these other kinds of tricks. And so that the eating disorder can pull to throw the parents off. So it really is often the case that Dina and I found that parents really wanted to be told kind of what to do, and rather than thinking of mastery as coming from the parents' instincts or past successes, we kind of think of experiential mastery as the key, meaning once parents have gone through the steps of successfully starting to refeed their child, and their child either starting to gain weight, it's that sense that really is what keeps parents confident and feeling effectful, I guess, if that's a word. So we see parents just really wanting specific direction, and from our perspective, it's not so bad to provide direction, really explicit direction, because we don't want parents kind of reinventing the wheel per se. Like each parent doesn't have to kind of come up with their own strategies, but if they are given strategies and they try them and they experientially learn, we think that that's really the key. So FBT also doesn't really address skills for patients at all. Really, it's a treatment that's done, yes, with the whole family, but really the therapist is talking to the parents about how to refeed and all of that. And there are no skills that are directly taught to the patient or the carers, really, nor are the patients ever taught to eat appetitively. Some of you might be familiar with intuitive eating. Intuitive eating is a lot more than appetitive eating, which is eating when you're hungry and stopping when you're full. But the gist of approaches like intuitive eating, health at every size, and the like in terms of eating is using your hunger and fullness cues, your body's natural hunger and fullness cues, as a guide to eating. That's not taught to patients in any way, nor is body image addressed. So at the end of treatment, you hear patients say, okay, well, I'm weight restored, but I still hate my body. And so there are these areas that, again, that we can improve upon, we think. And so there are also other issues as well. So carers, for instance, could have an eating disorder, or they're not able to put their child's needs first. They're not available. Maybe they're unwilling. And so there are a lot of issues that can kind of prevent a clinician from being able to use FBT. Some other kind of issues that can get in the way include a patient needing a higher level of care and figuring out how to integrate FBT in that way. So again, FBT is a great treatment. It's just that there are areas that we can improve upon. So again, IMT is an evidence-based practice model, and we kind of use FBT as a basis and a foundation for treatment, but we draw from CBTE, appetite awareness, compassion-focused therapy, ACT, DBT, etc. Okay, so there's a question coming in. It says, what do you do when the adolescent medicine specialist gives contrary directions to FBT? They'll say that adolescents can prepare his or her own meals. Yeah, that's a really great question. So what I do is I call the adolescent medicine specialist myself, get a release to do so, and educate that practitioner regarding what the evidence says is the best treatment approach. And if they're providing guidelines that to the patient and the carers that are contraindicated, I just let them know. And I kind of take a team approach. So if you're an outpatient therapist and you're practicing FBT or IMT or whatever, it's really important to make sure that you kind of take on the role of treatment care coordinator. So each individual patient is likely going to have a different treatment team. They're going to have a different MD, potentially a different dietitian, or endocrinologist, cardiologist, whatever. So you have to be the kind of point person, and I think put yourself in the position of keeping everybody on the same page. So I often send the AED medical care guidelines as well. So the Academy for Eating Disorders, or AED, has on their website, aedweb.org, a downloadable medical guide. So you can kind of give that to the adolescent medicine specialist and say, okay, so your job basically is described in this PDF. You're taking care of the medical stuff. Regarding the behavioral stuff, that's my domain. It's my discipline, and let's work together. But let's make sure that I'm not conducting lab tests on the patient, and you're not necessarily giving behavioral treatment guidelines. So I really like to kind of divide up the labor in that way and make the roles really clear, because I think especially in the treatment of eating disorders, fields kind of all get really murky. Dietitians are kind of doing therapy, and therapists are making meal plans, and doctors are giving behavioral guidelines. I mean, it's just a mess. So I really like to put myself in the position of clarifying the roles and making sure that kind of everybody stays in their lane in terms of discipline. Does that answer the question? Yeah? If not, just let me know. Okay, so basically, getting back to evidence-based practice, because FBT kind of has these areas where there are some kind of holes in terms of, again, like body image, skills, etc., and it doesn't take into account really treatment at higher levels of care, we decided to integrate everything into this one place. So IMT essentially is different from the treatments out there in that it tweaks FBT itself, and it really is what we consider to be a behaviorification of FBT. So for those of you who aren't so familiar with FBT, you might not know that FBT is actually atheoretical, meaning it doesn't kind of purport to be a cognitive behavioral therapy, a behavior therapy, third wave therapy, nothing. It's just atheoretical. It doesn't kind of come from any sort of kind of cohesive conceptualization. It basically is a treatment that says, listen, for whatever reason, we're not going to get into why, carers need to refeed their kids, and that's that. So as psychologists coming from behavioral backgrounds, Dina and I see behavioral principles everywhere in FBT. And so what we thought would be a good idea is to introduce reinforcement as a principle, and kind of these concepts of behavioral shaping and providing praise and the like to kind of best, I would say, optimize FBT. So within the FBT framework, how can we use tried and true behavioral principles that have been developed kind of in animals and people, et cetera, over the last 100 years and apply it to this treatment. So we've tweaked FBT itself by behaviorifying it, making it concrete, having handouts for carers, and the like. We've also included skills training for patients, including individual therapy is also something else that's new. So we have an eating focused therapy called RAE or RAE, regular and appetitive eating, and body image therapy or BAE. So the other thing that's different about IMT is that because Dean and I work at higher levels of care, also an outpatient, but we work inpatient and partial, we really were kind of acutely aware of the need for treatment materials to be used in groups and ways to kind of onboard families while in higher levels of care to the idea that they will be kind of engaged in an FBT-like treatment after discharge and the like. So we needed something flexible that really helped us in the trenches. And it includes concrete handouts for patients. So again, you can kind of use CBTE for adolescents, but this is really a treatment that is tailored for adolescents, and you'll see with the handouts. There's lots of graphics on them and the like that really kind of fits the population. So overall, our mission is to basically gather as many available interventions for eating disorders in one spot. For those of you who might know her, J.D. Ouellette calls this evidence-based practice in a box, which I really like. So the idea is that, a person, a clinician in a rural area who might not have access to trainings and treatments and that kind of thing might be able to pick the book up, read it, read about some interventions, and hopefully, start using them to some extent. And because of this evidence-based practice in a box approach, I've been contacted by people in rural areas of the country and of the world who are particularly interested in IMT. So in a couple of months, hopefully I'll be going to 2 Native American reservations who have reached out and said, we really don't have any resources for people with eating disorders at all, and we think that your approach might be able to be picked up pretty easily. So can you come here and teach us more? And somebody, Grace Schumacher from Alaska, has reached out and is really interested in this approach as well, because the idea is that it's kind of like a recipe. It's like a treatment recipe. So we really hope to help underserved areas with this. And we wanted to create resources for any type of eating disorder, not eating disorders yet, and provide a flexible and scalable approach. So, all of this kind of taken together, what we really want to do is help our friends and colleagues to close the treatment gap. So briefly, there are kind of 2 ways to administer IMT. There's a comprehensive way to do it in an outpatient setting from start to finish. And then there's the flexible version of it, which I use much more in my day-to-day life, being at a PHP, partial hospitalization program. So first, what we do is we take kind of FBT as a basis, and we kind of break down the stages into 2 stages. So stage 1, where parents are taking control, or carers are taking control of food, etc. And stage 2, when they're giving that control back. We pair this in an outpatient setting with skills training for the patient. So if you're familiar with DBT, there is 1 session per week of individual and 1 session per group. In this setup, we have 1 session for family and 1 session for group. There are 2 different kinds of groups depending upon which stage the person is in. So if a person currently has parents in control of their food, we have a mindfulness and acceptance group and kind of interventions that go with that for the patient. Because if you've ever tried to do cognitive therapy with someone with anorexia nervosa or really in the throes of an eating disorder, even if they're not underweight, cognitive therapy doesn't really work at all. There's no kind of arguing, Socratic questioning, thought record kind of approach that ends up moving the needle even a little on degree of belief in eating disordered thoughts. So we, similar to DBT, take the approach of, okay, if thinking in this Socratic way isn't really something that a person's able to do, let's focus on mindfulness. Let's focus on acceptance. To some extent, let's focus on dialectical thinking, because you can move the needle when someone's thinking very dichotomously with those kinds of approaches. So rather than introducing CBTE or CBT skills in stage 1, we have a mindfulness and acceptance group. Once weight restoration is achieved and patients are able to identify negative thoughts and they've developed some skills, we have a CBT group. So at that point, we introduce thought records, the kinds of negative thoughts, disputing negative thoughts, and the like. So after patients have graduated from both family therapy and the group skills, we move into a stage where there's actually 2 sessions per week. Both are individual. One is focused on what's called regular and appetitive eating, again, or RAE, where the patient themselves learns to eat regularly and appetitively. So yes, they have control back of food from their parents, but what skills do they have kind of internally within them to ensure that they will continue eating in a way that is psychologically healthy? So for instance, if you have a patient who is a senior in high school and just got control back over food, are you going to feel so comfortable sending them away to college without having developed any skills to regulate their own eating? So we were not comfortable with that, and so came up with this kind of hybrid approach that is Fairburnian CBTE food logs, and then also a kind of intuitive eating, health at every size, appetite awareness type of training as well, and we'll get into that. And then also the second individual session per week is focused on what we call body acceptance and exposure. So this really, this area focuses on decreasing maladaptive body-related behaviors. So there are eating disorder behaviors that are that are kind of eating focused. So food restriction, limiting the overall amount of food being eaten, food avoidance, avoiding specific types of food, and this kind of thing. In addition to behaviors that are aimed at reducing anxiety about weight gain after having eaten food. So we call them intolerance behaviors instead of compensatory behaviors in IMT. The reason for that is, as behaviorists, we don't kind of align with the eating disorder mindset of, oh, I'm compensating for calories by purging, but rather the behavioral conceptualization, which is emotions are being regulated through purging, and my anxiety about weight gain, my guilt about eating, my disgust with my body, those emotions will be downregulated with purging. So we call them intolerance behaviors because there's an intolerance of negative emotions, anxiety, guilt, disgust, physical feelings like being full, etc. So so again, sorry, with Ray, we're focused on mitigating eating and intolerance behaviors. But in Bay, what we are looking to do is decrease body focused behavior. So body checking to see if weight was gained, weighing oneself, tying, clothes around one's waist, so one's kind of hips and buttocks are hidden, and that kind of thing. So we target the behaviors. Then we focus on exposure exercises around fostering acceptance of one's body, and of course tolerating negative emotions. And then lastly, with body acceptance and exposure, we move into kind of a gratitude space, so gratitude for one's body, and the like, and that is really influenced by compassion focused therapy. So taken together, comprehensive IMT looks like this. There are 3 stages, there are 3 different modalities: family, group, individual, and kind of different modules within those modalities. And with IMT, in a flexible administration, you can really kind of get creative with what you're doing. So with bulimia nervosa, oh, P.S., you pretty much always, if you're dealing with outpatient anorexia nervosa, pretty much always want to stick to the structure. Not every patient is going to have every intervention. Every intervention it's impossible for every patient to kind of resonate with every intervention. So you're supposed to use the IMT handouts in this kind of a la carte fashion. So that said, within using the handouts in an a la carte fashion, this is the structure of the treatment. So you're still going to want to implement family stage 1 with the group material, but not every handout is going to be relevant for carers, and not every handout in the group material is going to be relevant, and kind of so on and so forth throughout. So although you want to kind of do comprehensive IMT for anorexia nervosa, there are different ways to use IMT for the other disorders. So for bulimia nervosa, you might want to do family treatment in the way that you would do it with AN, or you might want to kind of have these hybrid individual/family sessions where the family is walked through kind of how to be supportive to the patient, but not necessarily adhere to super strict treatment rules. So in the material, we have different handouts for anorexia nervosa, which we kind of conceptualize in IMT as both anorexia and atypical anorexia nervosa, because atypical anorexia nervosa really does, in practice, need to be treated the same as AN. So we kind of collapse those two. And for those of you who don't know what atypical anorexia nervosa is, technically the person doesn't have a body that is that is a BMI that is in the low weight range. However, that body weight is very kind of low, or is low for that person, and a person's weight has rapidly decreased. So for instance, a person may have lost 60 pounds in 4 months. And yes, their body isn't in the underweight range, but this rapid weight loss causes a lot of medical issues, and clinically it presents very similar to AN. So we kind of lump AN and atypical AN together into what we call AN disorders, and then we have what we call BOB disorders. And BOB disorders are bulimia nervosa, OSFED, or not otherwise specified, and binge eating. So if you have a BOB disorder, BN, not otherwise specified, binge eating, you can use the BOB specific handouts. And so again, they're not as strict as the other protocol, and you can figure out what balance is best for your patient in the first weekly session, and then in the second weekly session you can have group. Another way of doing this is not having family members involved. So we have Ray and Bay in the first weekly session, and you kind of progress through the Ray material, then the Bay material, and then group. Or you can have it so that Ray and Bay are in the 2 separate weekly sessions, or combined. And so it really is, it sounds like a lot, but I think once you get the feel of the material, it becomes pretty intuitive, and you kind of know what to use based on the level of severity of the patient and the symptoms they present with, and also the availability of the carers. So anyone has any questions, feel free to enter them in the chat box. If not, I'll keep plugging through with the kind of overview of interventions. So again, the FBT kind of section, or the family section of IMT, is similar to FBT but different. And for example, it includes concepts like self-eclipsing eating disorders. So in FBT, there's the overlapping Venn diagram model where we see the eating disorder kind of coming in front of the person and like hiding the person. We flesh that idea out a little bit more. Again, we introduce behavioral language. So we have something called RIBS and RABs, which are reinforcement interfering and allowing behaviors, and treatment rules. So we're very specific about what a SEED, or self-eclipsing eating disorder, is. It's a belief that eating disorder behavior should be performed. There's apparent intention to keep performing these behaviors, lack of ability to recognize functional impairment and ramifications of the disorder. This is also known as anosognosia in eating disorders, or is very similar to lack of insight in OCD. or it's the same thing, depending. And then again, lack of insight. So, so we really see that AN most of the time is a self-eclipsing disorder, and we see patients saying, you know, that and kind of insisting that they're overweight and the like. But basically, we do different interventions based on whether we have a self-eclipsing eating disorder present or what we call self-acknowledged disorder present, a disorder that is kind of akin to an ego dystonic disorder in the Freudian language, or a disorder that people acknowledge and they report wanting to get rid of. Reinforcement allowing and impeding behaviors. Okay, so a RIB is a reinforcement interfering behavior. And what that means is that we are trying to interfere with the eating disorder getting kind of auto reinforced. So within the context of having an eating disorder, again, behaviors that were called compensatory, we call them intolerance behaviors, like purging, that's going to reinforce the eating disorder. So every time a purging episode happens, a person gets further entrenched in the disorder because they are negatively reinforced through the reduction of anxiety, guilt, disgust, shame, feelings of fullness, thoughts about having an eating disorder, etc. So the more someone, again, engages in these behaviors, the more they're reinforced, negatively or positively, depending. So what we want to do with family treatment is make sure that a parent is interfering with the eating disorder being reinforced. And this is kind of a global concept that we talk about in lots of different ways. And I think that it helps the parents to understand what their kind of aim is. So you can think of it as not enabling, essentially. Whereas a RAB, or a reinforcement allowing behavior, is essentially enabling behavior. It's allowing the eating disorder to continue to be reinforced. So parents have it in their mind that the kind of goal is to interfere with as much reinforcement as possible throughout every day, and to not allow or enable the eating disorder behavior from occurring and from being reinforced. And then we have treatment rules. This is a list of treatment rules for carers of patients with AN. And it doesn't necessarily have to be adhered to so strictly with every single family. You're going to want to kind of tweak this. But essentially, we encourage carers to stick to this treatment rule plan. Okay. So a question came in, do I tend to use the word enabling with parents? Yeah, I would use the word enabling. More specifically, we use reinforcement allowing because I think that there's no judgment in that. Essentially, it just a behavior that a parent engages in is either going to interfere with the reinforcement of the eating disorder or it's going to allow it. No judgment, it just kind of is what it is. So group, okay. So again, we have our mindfulness and acceptance group and the CBT group. For other disorders, it's kind of less important for the ordering of it, but for AN, we want kind of the MAC group to be first, or mindfulness and acceptance, and the CBT group to be second. But on our inpatient unit, depending upon, or in our partial program, depending upon who is present, we use group material from both modalities. This is an example of the CBT kind of intervention where we have, the types of disordered thoughts on the left and examples of what they are on the right. This is from the MAC collection. It's a DBT-esque, acronym with skills in it. It's called Eat Meals. And so each of these lines is a specific skill that's discussed in more depth in the manual and in the handouts. This is just a little excerpt. And then this is a kind of compassion-focused exercise that we included, and it involves having patients imagine that they get to spend time with a little puppy, and that this puppy actually has a mean owner, and the owner causes the puppy to starve by restricting its food intake and makes it run around and makes it vomit and makes it sick. And just conceptualizing and I think feeling emotionally the impact of what eating disorder symptoms would be on a puppy or on a cat, for instance. It really just it gets at thoughts from a different angle. So rather than cognitively and Socratically questioning thoughts from an emotional kind of ground up way, imagining a puppy having these eating disorder symptoms just accesses, again, this emotional system, and patients really have usually a pretty intense reaction to this. And then from kind of the emotional place of understanding that this is what they're doing to themselves, they can maybe start to have some compassion for themselves and even other people with eating disorders who maybe they view as competition. So it really kind of gets people to at least temporarily switch from a kind of competitive, destructive mindset to a more, I would say, like collaborative and compassionate mindset. So I really like this exercise, and I know some of you know Dennis Tersch and Laura Silverstein, but they helped me with this one. They're really compassion-focused therapy experts, and I really think that this remains one of my favorite interventions in the collection. So we have things like this in there. So this is a kind of overview of regular and appetitive eating, and the three phases are basically establishing regular eating, so eating breakfast, lunch, and dinner, 2 snacks regularly throughout the day. And this also is kind of aimed at making sure the food volume is enough. So eating regularly and eating enough volume is kind of the first stage of regular and appetitive eating, and then challenge foods are introduced. And this introducing challenge foods, so in a very Joanna Steinglass kind of way, where a hierarchy of challenging foods is created and worked through in treatment. This decreases fear of specific foods and thereby the behavior of food avoidance, so avoiding specific kinds of foods, fats, pizza, sugars, ice cream, that kind of thing. And then we, again, introduce appetitive eating, so eating according to hunger and fullness cues, so we call that RAE. The reason why these two are combined is because both in practice and logically, it seems that one can eat both regularly and appetitively, even though the literature is really kind of seem to suggest that you can do one or the other. So in the CBTE manual, it says in bold, and I think it's underlined and it's in italics, it says, do not teach patients to eat according to hunger cues, which is fine in the first stages of treatment, and I don't think you necessarily should. But then there's all this research that shows that eating according to hunger and fullness cues is actually rather helpful, as it turns out. And so it has to be the case that you can eat regularly and appetitively. I know because I do. I eat breakfast, lunch, and dinner. I also, am hungry at those times, and I stop when I'm full. So to me, there was no reason to keep these fields separate. It just took some thought in terms of how to integrate them. And so we integrate them over time, with starting with regular eating and really prioritizing that and making sure that food volume and regularity is focused on as the main treatment goal. And then we can get to avoiding foods, and then we can get to appetitive eating. So that's how we have integrated those kind of areas of research and clinical practice. This walks you through the steps. So regular eating, food avoidance, and then appetitive eating. So we employ food logs to make sure that eating is regular and that a person is eating enough. example of a food log. And then over time, patients are logging the challenge foods that they've eaten on the right. And the therapist is really, coming from a behavioral framework, therapists are really encouraged to provide lots of reinforcement around these behaviors, right? So really good job eating breakfast within the time period that we set out. Really good job eating the appropriate amount of food, and really nice job including a challenge food of eating, or including, whole fat milk, this kind of thing. And so therapist really wants to be very specific with their praise and making sure that the patient is hearing those specific praises for all the behaviors engaged in. This is an example of a little excerpt from one of our appetitive eating handouts, where there's this hunger and fullness scale. And we kind of start defining behaviors in the appetitive portion of Ray as, a behavior that is not consistent with recovery is overriding feelings of hunger, stopping before you're full, eating when you're already full, and eating way past the point of being full. So those are the behaviors that we want to try and shape with reinforcement. And then what you want to kind of steer towards is eating when you're hungry and stopping when you're full. Okay. And then it's hard to see with my, with my setup here exactly what time it is, but I think we have some time left. So, so with body acceptance and exposure, we have 3 different kind of steps. One, abandoning attempts to change your body. So decrease, again, body-related maladaptive behaviors. So body checking, body avoidance, tolerating internal negative experiences such as emotions and fullness and the like is next. And then working on appreciating your body, 3. So for decreasing eating disorder behaviors such as body avoidance, we use the NIFTY skills. And the NIFTY skills are noticing the urge to avoid your body. Instead of avoiding your body, challenging yourself, feeling negative emotions, shame, worry, and so forth, and thanking yourself. That's the TY. Thanking yourself and acknowledging that you took this step in line with recovery. So the reason why things are kind of ordered in this way is that we kind of want to start with mindfulness, then move into a mindfulness of the urge and the issue that's coming up, wanting to avoid, shifting into challenging yourself rather than engaging in the eating disorder behavior. So choosing recovery. By choosing recovery, you are going to be unfortunately punished by feeling negative emotions rather than negatively reinforced through the eating disorder and feeling better. So you're actually going to choose recovery and feel worse, and tolerating all of that, and then reinforcing yourself. So starting to auto-reinforce recovery rather than auto-reinforce the eating disorder. So the reinforcement comes in by thanking yourself and taking some time to sit with this idea that you did the right thing, and then kind of even after this, like generating positive feelings of maybe pride and accomplishment that that can come with, again, choosing recovery. So it's a bit harder than body avoidance, but well worth it. And then we have the rock skills for combating body investigating behavior or body checking behavior. So first step is kind of overall remove temptation. So if you're at a place where you are checking multiple times a day, making sure that the scales are hidden, mirrors are covered, throwing out the skinny jeans and so forth. So you want to walk your patients through that. Interestingly, when I have asked patients in the past to donate skinny jeans or to donate clothing that is too small for them, I very consistently get the response of, I would rather burn the clothes than donate them. And the reason being that this kind of competitive eating disordered thinking comes in, and the idea of donating is really scary because somebody else with an eating disorder might get those clothes and might look good in them, and then it's not fair that I can't have these clothes and I can't fit into them. And so I, again, working from a compassionate kind of standpoint, try to walk patients through this idea of, okay, well, what if a person who's less fortunate gets them? What are the chances that it's going to be someone less fortunate? How would you feel if you were to donate something else that, maybe wasn't clothes or food to someone in need? Would that, like a blanket, would that feel good? Okay, so it would feel really good to donate that. It's also, you're doing a really good thing by donating these clothes as well, and trying to, again, shift away from this like competitive eating disorder kind of a mindset to this compassion focused, pro-social, I'm doing something good for not just myself, but someone outside myself. So anyway, that's just a little side note within Remove Temptations, where I always push for the donation of clothes, not the throwing out of clothes. So observing urges to engage in body investigating behaviors. So kind of a similar step as the nifty skills, where there's mindfulness. Now we have patients catch negative and positive determinations about their body, meaning I look in the mirror and I think I look really good. That would be a positive determination. And looking in the mirror and thinking, oh, I look really bad. Because either way, whether you think you look good or whether you think you look bad, within the context of an eating disorder, they're both judgments, and they both can reinforce eating disorder behaviors. So let's just say I starved myself all morning and I looked in the mirror and I thought, hey, I look good. That thought, I look good, reinforces the starving myself all morning. So either way, it's not a good thing. We're not trying to get patients to think that they look great. We're trying to move the mindset away from judgment and towards non-judgment. So we provide a lot of education through the materials about why negative and positive determinations are both equally as unhealthy. And in fact, positive determinations can be even more destructive than negative determinations sometimes from a behavioral reinforcement standpoint. So so we want to make sure that patients are catching, again, negative and positive determinations or judgments, and then know that after a body investigating behavior, both of these kinds of determinations are part of the eating disorder, and stay the course. So regardless of what the determination is, don't let the roller coaster of thoughts, urges, and emotions get you off track. Just continue doing whatever you're doing. So it's kind of similar a little bit to the DBT skill of turning the mind, where it's like, okay, so all of this stuff is happening, and my eating disorder might be reinforced, but I'm just going to, if I was walking down the street and I stopped to look at myself in a storefront, I'm just going to continue walking down the street. So the behavior replacement is doing whatever it was that you were doing prior to investigating yourself. So we always want to give patients, a replacement behavior. So instead of just saying, don't judge yourself, don't, look in the mirror, the behavioral replacement is get your mind back on track and do what you were doing. And it's kind of open because they could have been doing anything. So we, as therapists, would need to plug in the information there and kind of ask patients, okay, were you walking down the street? Were you in ballet class? What were you doing when this happened? And how can you turn your mind to, getting back to business, kind of a thing. So these were how to decrease behavior, body avoidance, body investigating or checking. Then there's exposure. So we have our patients engage in a lot of imaginal exposure exercises in BAY. And these are my favorite interventions within the BAY group, because I think they're probably the most effective. So my dissertation kind of hinted at some of this. I did a study and I was examining thought suppression. So trying not to think about certain things, trying not to think about food, and then you think about food more. As it turns out, thought suppression is important in terms of a treatment target, but what's way more important by leaps and bounds, I mean, immensely more important than thought suppression, ended up being fear of fatness. And it turns out that fear of fatness really maintains so much of eating disorder behaviors. And I started thinking to myself, well, by targeting food, we're not really targeting fear of fatness. We're targeting fear of food, and food is associated with fatness, but that's not the same thing as fatness. So what would you need to do to target fear of fatness? Well, we have imaginal exposure as a tool in the treatment world, the anxiety world, the OCD world. So imagining weight gain, imagining negative consequences of weight gain. I gained 15 pounds and my boyfriend dumps me. I gained 15 pounds and I'm no longer the star athlete on my team. These kinds of fears are really the fears that I believe are the crux of the eating disorder. And what my dissertation showed years back was really that fear of fatness was one of the most important variables. So to target with treatment. And Sherry Levinson's work at the University of Louisville is really kind of showing some promising stuff with using imaginal exposure to target fear of fatness. So that's very encouraging. So we have a bunch of different imaginal exposure exercises that we use. I really like this one. This one asks patients to imagine that they're exactly the same body size, shape, and weight, no matter what they do. So they can try and restrict, get liposuction, purge, whatever it is. Their body will return to exactly the same size, shape, and weight as it is now forever. And I ask patients to kind of imagine what this would be like. And the reason why I think this is a kind of a good one is for two reasons. One, it gets patients to kind of think about what it would be like to have to accept their body. Essentially, there's nothing that they can do. So they would feel all of these negative emotions. But at some point, most patients say, well, I mean, I guess I would have to accept it, and I wouldn't like it, but what am I going to do? I just have to give up the eating disorder behaviors. And then if they think a little bit down the road from there, it's like, oh, that actually would free up a lot of time, and maybe my life would be a whole lot better if I accepted that this is what my body looked like. And what you can say is, well, yeah, sure, your body might stay the same, or it might not. It could gain, you can gain a little weight, you can lose a little weight, but essentially eating disorder recovery is experientially going through those processes of feeling all of those negative emotions, accepting your body, and then getting on with your life and not having all the eating disorder stuff in the way. So this is one example of an imaginal exposure exercise. Another one could be creating a script where, again, like a patient gains 15 pounds and loses a boyfriend, that kind of thing. So really walking patients through kind of the worst case scenarios, and so they can process this. Okay, great question. Are parents included in the BAE process? Are they told it's being done? And what tools are they given to cope with this at home? Okay, so BAE is specifically done within the individual therapy context. At the end of family-based treatment, parents are informed of what will be what individual treatment will entail, both with the regular and appetitive eating and the BAE exposures. Typically, the BAE exposures are done in the context of individual treatment. So the therapist reads a script like this, and the patient processes the emotions in session. Sometimes parents could be present for that hypothetically if they want to come to the sessions or told about it. In the past, I haven't had parents involved in this, and typically we do this with patients who are doing fairly well in their recovery. So you wouldn't want to do something like this when someone is underweight per se. We think Sherry's work maybe suggests that you can do it when people are underweight, but in the context of, for instance, treatment, when a patient is enrolled in inpatient treatment or partial hospitalization treatment, they're anxious all day. They're at a 10 all day because they are preparing to eat, eating, feeling full, preparing to eat, eating, feeling full again and again and again and again throughout the day. So their emotions, because we're so concerned with making sure that the patient is eating and that they're nourished, we're not so concerned with the kind of classic exposure setup of, exposing someone to a spider and having their anxiety peak and then having that anxiety slowly come down. And so because we don't have that setup, when you introduce an exercise like this, there's no way for the emotion to kind of down regulate because the patient's about to go into the next meal. So we typically don't do this in family treatment because the food exposure piece is so intense. We do this after family treatment. We don't typically do it at higher levels of care either because, again, it's so intense. So at home, that said, I have given some homework assignments. So at some point, after a patient is able to tolerate these exercises in session, what I'll say is, okay, so you're only getting to, a 5 or a 6 when we do these exercises, and you're not having urges to purge or urges to restrict. So why don't you try this at home for homework and read this script every day to yourself? I gain 15 pounds and I lose my boyfriend, and sit with it. And when you're able to do that, in my clinical experience, the fears extinguish much more quickly because the patient doesn't have to be in therapy with you to go through that. So it really expedites the process, but it has to be in a context where a patient is not going to engage in a compensatory behavior, and it kind of has the tools and the internal resources to want to recover at that point. All right. And again, kind of the last stage of BAE is fostering gratitude for one's body. So trying to develop a positive relationship to/with the body. Not judging it positively, not saying I look so fabulous, I look great. It's not about looking great. It's about, again, having a positive relationship to your body where you are grateful, for instance, that it functions and that you have legs to walk. And we try to move away from the reductionist eating disorder view that one is the body, and more than that, one is the way one's body looks. And we try to move into an expansive place where the person starts identifying their kind of internal characteristics as who they are and not how their body looks as who they are. And so we try to focus on kind of identity development and expansion, and body gratitude is kind of one part of that. So that's basically the slideshow.